Welcome, everyone. Thank you for joining our three-part webinar series. My name is Jordan Hines, and I am the New Initiatives Coordinator at the Epilepsy Association of Western and Central PA. The series is going to guide participants through the GOT transition 6 core steps of healthcare transition, and each step will take about 10 to 15 minutes. So this month's webinar is titled From Takeoff to Landing, which will cover steps 5 and 6, transferring and completing. Our featured presenter is Dr. Anto Bagic, who is a professor of neurology and neurosurgery at the University of Pittsburgh Medical Center, where he serves as the Chief Epilepsy Division. He has published over 130 articles, abstracts, and book chapters, and is very passionate about creating a smooth transition for adult healthcare for youth living with epilepsy. So please join me in welcoming Dr. Bagic.
Thank you very much, Jordan. It is my pleasure to participate in any activities that Epilepsy Association arranges, and this one is really close to my heart because I face negative ramifications of unprepared transfer and transition practically weekly. So that's why I'm very passionate to hopefully contribute to mitigating this problem. As Jordan had said, we are basically discussing the final phases of this process. And let's go quickly over the goals for this presentation. First, of course, is to identify practical steps in choosing an adult epilepsy provider. We will dwell into specifics, what is different between neurologists and epileptologists, who needs really to be in epilepsy center, and eventually who can be served perfectly by co-management arrangement that we get into sometimes. Of course, it's important to know what to expect when you see your new epilepsy specialist, because pediatric world of epilepsy and adult world of epilepsy are simply different. There is nothing worse or nothing better. It's just simply different how everything is arranged, and it's very important to be cognizant of it. So there is, of course, appropriate upfront preparation, and there is no unpleasant and negative surprises. Of course, additional very important goal for today is to identify some resources that can help support appropriate preparation and navigation to the process. So as Jordan mentioned, there were previous 2 talks that addressed, first Dr. Asato and Dr. Krumran addressed discovering and tracking, then Dr. McCormick, I believe, went over preparing and planning. And basically today we are really talking about transferring and completing a process of, transition that is simply called transfer. Now, what is important to realize that different offices, practices, and even the same office and the same practice at different times, depending on regulation, may have different policies, if you will, as to transition. So it's really critical that you talk to your current pediatric provider as to, when is the right time for transition. Just to reflect on reality, nominally, of course, it's 18 years, right? And that's how basically populations of patients served in Children's Hospital and in, adult center are defined. Everybody under 18 goes to Children's Hospital. Once patients turn 18, they should go to adults. Now, of course, everybody is aware of Obamacare and such, that those of us who are parents, of course, we can keep our children up to 26 years old on our insurance policies. And due to various practical ramifications, this led to this situation that sometimes we have obviously young adults in their 20s, they are still served in children's, and then they transition. I can tell you one thing, after participating in this process as an adult epileptologist over the last 15 years, that transition actually is harder if patient transitions and ultimately transfers at later age. So in my opinion, really optimal time for transition is 18, and only with very specific reasons, patients should stay longer on pediatric side. Of course, once you get appropriately counseled by your pediatric provider as to when is the right time, then of course you become cognizant of steps. And pretty much all of this has been discussed in 2 previous presentations. Now, again, I cannot overemphasize the importance of awareness of where resources, support resources are, because trust me, no matter how well versed you are, there'll be certain things where you will scratch your head and say, oh gee, what do I do now? Well, this is what you do when you reach that point. You contact Epilepsy Association. Also, it is really great resource, that there is this adolescent medicine clinic at Children's Hospital, and you see direct number and provider there where an appointment can be scheduled, and apparently this is great resource that is specifically designed, obviously, for this purpose. So let's now get a little bit more into specific transition versus transfer. So what are really differences? So transition, you can say, is basically this entire process. When you start talking to a pediatric provider, and we advise actually that you start the process sometimes early teenage, 12 to 14 for many kids is right time. For some, maybe later. Rarely it's earlier. And that's basically when preparation for transition starts. And you can say even transition starts at that time. And entire process up to the moment when you see your provider, your adult provider, and you basically completely sort of cut your umbilical cord with your pediatric provider, that's basically everything is transition. And that very last segment is transfer. That's when you really transfer your records to your adult provider, when you meet your adult provider, and perhaps after a few visits, when you completely sync with your adult provider, that's when you can say, okay, transfer is complete. And I already explained all of this. Now, when you're transferring, you may be coming from a different environment. In your immediate area, you may have just some general neurologists who then see everybody. By the way, neurology includes more than 600 diseases. So you realize we subspecialize like we do it in the whole of medicine. So what are some differences? Well, obviously, neurologist is somebody who treats anyone with any neurologic disorder to a certain degree. Once something goes above their, level of comfort, then of course they refer to subspecialists. Now, epileptologists are neurologists who actually undertook subspecialty training. And nowadays, since 2013, we actually have an accredited training. That means there is a very structured program through which any neurologist who wants to subspecialize has to go in an accredited place. And then they even take board to be boarded as an epileptologist. So what that means at least 1 year, and some of us spend 3 or more years actually in this training due to research and various other things. So this is neurologists who really have more in-depth knowledge of all aspects of epilepsy care, including non-pharmacologic options, such as surgical options and such. Obviously, any competent epileptologist has to be intimately familiar in any aspects of diagnostics, neuroimaging related to epilepsy, and electrophysiology, meaning EEG, and related diagnostic procedures. Now, there is shortage of neurologists, and there is shortage of epileptologists. So not everybody will have choices. What is also important that we have these specific specialized entities called epilepsy centers. And there is actually a document that regulates how these centers are established, what they have to have in order to meet requirements for an accreditation. My advice to anyone, but anyone literally, whose seizures are not completely controlled, is to see a provider in epilepsy center. And I don't care which one you go to, I do care that you go to one of them. And I will repeat, anyone whose seizures are not controlled should be followed in epilepsy centers. And you will see later on, towards the end, I have a slide, and you will see that we currently have 246 epilepsy centers that are accredited in this country. And this very area, you have at least two. You have a UPMC Epilepsy Center that is among the largest in the country. You also have a AGH Epilepsy Center. Again, I repeat this, and I know I said it a few times already. I don't care which one you go to. I do care that you go to one if your seizures are not controlled, because it makes big difference. Now, you remember in my introduction, I mentioned this option of co-management. And what do we mean by that? Let's say you live 3 hours from Pittsburgh or any other place where you can get to, an epileptologist. Well, then there is this arrangement, co-management, where basically you would have your local neurologist who would see you more frequently, but your really epilepsy care would be guided by your epileptologist, let's say in one of Pittsburgh's epilepsy centers or any other epilepsy centers. I think it's very important, and I have a slide on that, that we, don't forget also that nowadays we use epilepsy and e-visits. So this is a big push. Of course, it came because of the COVID, and CMS and all these regulatory bodies allowed us to see patients via various virtual means. And I honestly feel this is going to enable us to provide better care for our epilepsy patients, even once we are out of this COVID situation. Of course, I'm hoping that regulatory bodies will allow us to do this. So again, I want to stress, let's not forget teleepilepsy. So for instance, I spoke to one of my colleagues just now 10 days ago, and basically he practices around Harrisburg area, and he said, well, I really would like to see if we can explore some arrangement. And basically we are working on having consultations that we would provide to his patients in their home using, video means. And nowadays, when all of us are working with some kind of mobile device that enables, video communication, these logistics are really ubiquitous, I would say. So we should not forget that. I think this opens up very important possibilities. So again, we are stressing this sensitive period. It is, when somebody is taking baton, taking torch from one person to another. So we want to ensure that that handover process really goes optimally. And that's why one should go to checklist before you leave your pediatric provider. And at the top of that, by that moment, you really and family need to understand diagnosis completely. Because if you've been served in pediatric centers, such as our Children's Hospital, where they also have access to all diagnostics and all of that, you shouldn't be leaving them without having clear-cut understanding of your type of epilepsy and such. Next very important thing is medical summary. Nowadays, everybody can carry one of those on various devices as digital file, but of course, importance of previously used medications, results of diagnostic tests and such. And we developed between Children's and us, we developed this, transfer summary, where basically before you leave, if you work with them, then one of their PAs or registered nurses or somebody under the guidance of their epileptologist will fill up this transfer summary, where basically they will include all the information available on their side that are important when you come to our side. So that becomes your portable medical summary. And trust me, that is really best framework for discussion when you come and meet one of us adult epileptologists. Now, please don't be irritated. This is for you. This is for your care, that we re-ask multiple times questions that you were already asked and you were fed up answering. There is reason for that, because it's not that rare for us to get different answer after we ask something third time. So we really need to understand, have full understanding, of your epilepsy and connect with you in order to provide the best care. Of course, decision-making is something that you need to talk to your pediatric provider. As you will see on subsequent slides, once a clock ticks 18 years old, many things change. And that it's very important that you are ready for that change. Now, again, as I alluded to, handovers are the weakest links usually, and that's where many things can go wrong. So it's very important that you have provisions for emergency before you really establish care with new provider. What do I mean by that? You're leaving children's, you're scheduled to see me, let's say, but you have no working relationship with me. We never met. And then, boom, emergency happens. Who do you now call? Your pediatric provider, or do you call me? So provisions for this situation should be made to avoid any unpleasant surprises. Now, I alluded a few minutes ago about the importance of medical decision making. So those of you who are listening who may be young adults, but it's important that parents listen, and parents already know, but just reminders for them. Once you turn 18, things change. Then your parents actually has to ask for permission to access your medical records, be present at your visits and such. I'll tell you honestly, I was completely oblivious when I basically called my insurance for my daughter when she went to college. And I'm calling routinely and I'm talking, and then lady said, "I'm sorry, sir, I cannot talk to you." And I'm like, "Excuse me? You cannot talk to me? I'm primary insurer on this, I'm paying all of this." She said, "I'm sorry, sir." And then of course I took a deep breath. I realized, I was obviously not following something that I should know and know, but obviously disregarded in the heat of the moment, okay? So please remember that. Now, your qualifications for medical assistance, social security, and other basically supportive programs may change once that clock ticks 18. So it's very important that you become aware of all of this, because again, it sometimes feels like you walked into a new reality. Like it's, you're in a theater and, they turn the, podium, and on the other side, there is different scenery. That's how it sometimes may feel. Again, you are legally responsible for your healthcare and many other things once you are adult for all legal purposes. So, you don't, I'm sure everybody resonates with this. If you try to dance for the first time on your wedding day, I doubt you will be able to dance. Likewise, you don't wait 18th birthday in order to start addressing these things that are inevitable, predictable. So you work on them in advance. Well, not everybody, of course, can attain complete independence. So there are various ways how people can participate, young adults, according to their abilities. So for instance, those who are not able to attain complete independence, they can participate in other ways, such as some of these listed here. Help, filling pillbox, basically be cognizant to the degree, to the details that they can about the emergency plan. Of course, participation in epilepsy association activities is highly encouraged, and I encourage all my patients. That's one of the first questions I ask them. And then, of course, keeping records. In other words, developing that habit of basically being responsible, being engaged in care. And of course, parents should think do their teens have a transition plan that addresses independence in healthcare? If not, there are resources, and those two are listed here. And the stu.org, apparently great resource. I personally never accessed it, but I was told from few different people that it's great resource. And of course, Epilepsy Association, it should be in my book, your first and last thought with any struggle that you may have in relation to your epilepsy. So medical decision-making is obviously a big thing. You remember what I said. Once you turn 18, and if you attain complete independence, parents even can't call without your permission and say, hey, Dr. Bagic, what do you think about my son or daughter, right? So there are different ways to make these decisions and basically make arrangements to the comfort and ability of parties. And there is a spectrum of legal options, from shared decision-making, where it's basically interactive partnership over power of attorney, healthcare representative, to full guardianship. And full guardianship, obviously, is most restrictive legally, most restrictive option. And that's really when, patient is not really able to make decisions. Again, there are resources for help. Achieva was interestingly founded in 1951 by parents of children who needed help. They are a non-profit organization, and again, great resource. University of Pittsburgh has also Pitt Health Law Clinic. And of course, at Children's Hospital, there is social work where you always also can turn in the case of ambiguity. And when you reach situation when it's sort of gray zone, you don't know where to turn, where it belongs to, going to social work is usually prudent because they can redirect you effectively. Of course, advanced directive, unfortunately, many people ignore this until a situation becomes critical, and it's really too late to address things constructively. So, it's like, starting preparation for a fire at the beginning of the fire. You don't wait, you prepare in advance. Likewise, advanced directives should be something that is discussed with the family and, appropriately, addressed. Again, earlier, better is kind of revolving theme. Now, there are other things to discuss, right? Remember, young adult is turning 18, maybe they're moving away to college, they're making different living arrangements. Well, at home, parents stay on the top of things. Once you leave, you change your lifestyle. One of the elemental things that is going to change is your sleep hygiene. Well, nowadays, we think that everybody needs at least 7 hours of sleep at regular sleeping hours. A refreshing effect of sleep on your brain is not the same if you sleep during regular sleeping hours versus if you sleep during the day. And as you know, lack of sleep is among the most frequently, cited trigger for many persons with epilepsy. I simply tell my patients, avoid alcohol and non-prescribed drugs. Of course, we cannot make anybody do anything or not to do anything. We can only advise. In everybody's best interest, that is advice we give invariably. Reproductive health. Of course, both males and females should have a certain degree of, information and understanding about this. But it is really important, and I cannot overstress this, that really care for pregnant woman starts way before she ever thinks about getting pregnant. Being on the right medications, obviously contraception and such, in possible interaction between medications and contraception, and on and on. So this issue really needs to be addressed appropriately. Probably everybody on the call knows that unfortunately persons with epilepsy frequently have various mood issues. And prevalence of anxiety, depression, and other mood disorders is 5 to 10 times higher among persons with epilepsy as compared to general population. So this issue is very important, that things are not kept under the rug and ignored for a long time. It is much better to intervene early and provide effective care while it's more effective and easier. Of course, SUDEP is very important to discuss, what stands for sudden unexpected death in epilepsy, and we will have also a slide on that. I already stressed that this is, leaving home and all that is risky time for transition for many things. So if you leave your home or if you send your child away from home, please make sure that they are completely cognizant of the importance, obviously, of taking medications regularly. Mom and dad may be taking care of medications till that point, but later on, it is your responsibility. So you can't call your provider and it's Friday, 6 p.m. and it says, I am really out of medication. Well, that's not what you call. You call your provider when you get a bottle that says 0 refills. At that time, you're covered for a month or 3 months, depending on the prescription. And then you contact your provider. There is plenty of time for them to renew your medication to ensure no interruption. Of course, making arrangements how to get help. When you are at home, your parents took care of that. There are certain provisions. There are neighbors. There are family members. There is a list of phones and such. Well, when you are living somewhere else with somebody else, this whole premise changes. So you got to be cognizant of these changes, and you have to know who eventually will do what in the case of emergency. We already mentioned sleep deprivation. Should I even start talking about, traditionally colleges are not actually associated with most regular sleep times, right? And there are various other activities that take place. What is all basically negative in terms of, seizure control. So risk for seizures increase, and you got to be cognizant of that. Okay, so I mentioned that we will touch a little bit on SUDEP and other aspects of safety. So as you know, SUDEP stands for sudden unexpected death in epilepsy. Some people in the past used also sudden unexplained death in epilepsy. What that basically means, that means that persons with epilepsy, a person with epilepsy in their usual state of health dies of unexplained cause that is not related to anything identifiable or to something acutely related to their seizures, such as status epilepticus and such. Now, what's important, there are important risk factors. The key modifiable risk factor is seizure control, particularly convulsive seizures, generalized tonic-clonic seizures, and seizures at night. You probably realize when a person sleeps, if they experience seizure, they are on higher risk, and there are nowadays various monitoring devices, and actually Epilepsy Association already had great programs, I believe last year on that. The role of drugs, alcohol, and sleep deprivation in lowering seizure threshold was already mentioned a few times, and sleep safety obviously is big issues. There are monitoring devices that can be installed. Of course, it's very important if a person lives with a roommate or somebody, that roommate is aware of situation, so that they don't get shocked, startled, and panicky once they witness seizure for the first time. There are other things to address, such as obviously, insurance, as I mentioned, when I called for my daughter and, couldn't talk about it, couldn't get her new insurance card that she lost, right? So it's very important to have insurance and to have appropriate insurance. Avoiding falls and burns, it's obviously self-explanatory for those who are controlled. Driving safety is very important, obviously. Driving is a cardinal aspect of independence and function for most people. So obviously it poses also risks. So in that respect, it should be handled very sensitively. Again, I already mentioned, reproductive health and avoided unintended pregnancy. Perhaps this is a good point to stress one important thing. No matter what we as parents like to tell our kids, statistics show that at least half, if not more, of pregnancies are unintended pregnancy. So when I have conversation with my female patients and they say, "Oh no, doctor, I have no plans to get pregnant," I said, "I'm not even talking about that. It's my obligation as your epilepsy doctor to explain to you that you should be taking folic acid as a protection in the case of pregnancy and such, that you should be addressing, contraception, that you should be thinking this and this and this." And usually it raises some eyebrows, but then when people get surprised, then of course everybody realizes how appropriate and in fact not appropriate, necessary and critical these early discussions are. Hardest population to treat is females of childbearing age, because choice of medication has to be limited. And that's why I already mentioned before that really a care for pregnant females starts way before she ever, thinks of getting pregnant, meaning you have to have females of childbearing age on appropriate medications that don't pose risk for pregnancy and for fetus, and that is obviously cardinal and should be worked on in advance, because as you I'm sure know by now, that changing seizure medications is not like switching antibiotic. You stop one, you start the other, whole process that takes place. So you're getting ready for your first visit with your adult epileptologist. You identify appropriate person. What you want to do, you have you scheduled appointment and all of that, but you want to call them and ask of anything specific you need to know, from practical trivialities, where to park, how much in advance to come, are you going to be asked to fill certain forms, are there forms perhaps available on the internet, or in fact, is it pre-requirement that you fill some forms digitally, even day in advance or week in advance, in fact. So, and particularly, you want to call if you need any accommodations. That should be self-explanatory. Now, you should ask, what should you bring, right? Of course, insurance, cars, ID, and all that. Anything else? Many of us, and probably all of us, I should say, like to see patient coming with seizure log diary, right? If seizures are uncontrolled. If seizures are controlled, then of course that's self-explanatory. Now, what record should you bring? Even if you're coming from children, I think it's prudent to call our side and say, okay, I'm making sure that XYZ is there, because it's very frustrating, primarily for you, for both of us, but for us, it's a job. We have to deal with it, but you don't have to. So, it's going to be frustrated when we tell you, you're coming from a place that is maybe 20 miles away. Well, we don't have access to their records. We cannot discuss MRI. And you really wanted to know, what does adult epileptologist thinks about some lesion on MRI, right? Sometimes they may be able to tell you what you need to know even without looking at MRI, provided that what you are telling them is correct, meaning what kind of lesion and such, of course. But many times that's not the case. So it's so frustrating when then we ask you questions again and say, didn't they write all of that in the transfer summary and such? Well, again, sometimes we ask to re-verify, and trust me, it is in your best interest to assure absolutely as early as possible that everything is accurate. Now, I want to illustrate to you how actually pediatric and adult care differs. So I'll give you 3 examples. So here's the first one. For instance, there are resources on pediatric side that don't exist on adult side. And again, that's just simply nature of the things. So for instance, the cerebral palsy and related disorder program that exists in children that includes all these listed resources. Well, there is no analogous entity on adult side. So let's say a patient who has cerebral palsy, who has been attending this clinic for years and is used to this centralized, orchestrated, and coordinated care. When you come to us, well, we see you as an epileptologist. The rest of this is going to be you connecting with various entities on adult side that are providing these types of services. So again, this is not going to change due to the fact that we together complain of this. But as I said, it is just how medical practice is organized on adult side. There are some resources that simply don't exist on adult side. So everything on previous slide exists, but you have to approach these various entities individually. For instance, if anybody is attending ketogenic diet clinic in children's, we don't have such resource on adult side. So probably what we would suggest in that instance that you continue with, ketogenic, a diet clinic in children's while you see us and we manage the rest. And number 3 is really case example that actually illustrates some of the points that will be specified on the following slide. So here's an example of my patient, college student, who is coming to me for a second visit. So he's a college student at Slippery Rock. He had seizures since 7 years. They are controlled. He lives on campus, and mom picked him up to bring him to an appointment. So, of course, as you may get hint from this cartoon, he comes with headphones on his ears and just doesn't say anything, sits in a chair while his mom eventually tries to, run a routine. When I ask any questions and I look at him, he just points to his mom. Basically, well, mom is somebody who is going to answer questions. So look, this is notorious example how things should not be done. You see, this violates everything we've been saying so far. And when I asked mom how can she be sure that what she's telling me is correct, she said, oh, I rely on him. He calls me every time he eventually has seizure. And I said, well, does he, live in college and attend regular classes? Yes. Why can't he tell me directly what's problem? And she said, that's what I always did. Well, now I'm sure it's clear to everybody, this is where there was no trace of transition and transfer, right? So more specifics before we close. So how pediatric care on the left differs from adult care on the right. So in pediatric care, parent is presenting during visit, talking. When you are on adult side, we expect you, young adult, to talk to us. Of course, if you are unable, then that's a different deal. In pediatric side, parent helps explain history, medications, everything. On adult side, it is your role. Medications, refills, and such on pediatric side are responsibility of parents. On adult side, it's your responsibility. Making appointments, insurance, copay, all this deal, right? Pre-approval of medications or such. Parents handle all of that in the background for you on pediatric side, excuse me. And on adult side, it's your responsibility. Parents are, record keepers of vaccines and everything else. Well, you are when you come to adult side. So I think this slides quite clearly kind of builds on 3 previous slides that I tried to illustrate. So if any parents are listening, please allow your young adult and encourage them to start practicing talking for themselves early. I cannot overemphasize the importance of practice. They should start practicing when you are there with them in pediatric office so you can correct and direct them. It should take place in children, as I already mentioned. And of course, you may want, depending on their ability, to expose them to certain, exercise as to try to anticipate what questions may need to be answered and such, or what questions they may want to ask their adult provider. So once you crossed over to adult side, you should continue to work on building your independence. What is good practice after 1, 2, or 3 visits, maybe provide some feedback to your previous pediatric provider, and hopefully they're open-minded and they can learn something. For instance, you can provide feedback about something that you found to be suboptimal, something that could have been addressed better and such. So then they correct their practice for their patients. If you have other types of transitions, such as housing, living arrangement, and such, then they should be done in staggered way, not everything at once. This slide purpose is that it simply lists 4 websites where you can get really help on these issues. And these are mostly in some ways either related to, PA Department of Health or, Epilepsy Association of Western Central Pennsylvania. I would say if you forget everything, please try to remember these 2 points. 1, your number 1 ally that would enable you to have your best chance for seizure control, for seizure freedom and normal life is Epilepsy Association, and their numbers are listed, and I'm sure you're aware of them. On the other hand, National Association of Epilepsy Center, you can plug in your zip, and they are going to show all epilepsy centers around you, depends what radius you choose. I mentioned already that for 2019, we had 246 epilepsy centers that are accredited in the country. 192 are highest level, such as ours here, and 54 are level 3, what means 1 level down. I want to thank you for your attention. I want to mention that I'm greatly thankful to Dr. Asato for preparing materials for this presentation, and of course I would be happy to answer any questions. Thank you very much.
Thank you very much, Dr. Bagic. I had a few questions. Many youth have expressed to me that they have a fear of saying the wrong thing on their first appointment with a adult neurologist. So what would you say to a new patient that kind of help them build their confidence in their doctor?
Yeah, great question. So I'm known to say that transparent and trusty relationship between epilepsy patients and their doctors is the vital link that enables effective care. And I mean it literally, transparent and trusty. What that means, of course, on one end, and I know I will get to your specific question. So on one end, everybody is probably aware, we have no way of knowing if something that we are being told is true or not. We don't know what happens at home. If patient comes and says, I had 3 seizures or I had no seizures, there is no way for us to verify. So we rely on that trust and transparency. That is critical. Likewise, one of the consequences of that is I encourage patients to talk freely and to say whatever they say. It is my role actually to correct that. And it's better to do it early than later, because later basically it muddies water. If there are misunderstandings, there are sometimes situations when somebody may be using wrong terminology for certain types of seizures. Well, you realize, you come, nobody corrects you, and then you say, I have X many of certain type of seizure. And your doctor takes that into consideration. That, in fact, is vital input into decision making. And you know how they say in computer world, garbage in, garbage out. If there was no upfront clarification what it actually means, wrong decisions could be made. So I actually would encourage all patients to talk freely. It's doctor's role to educate, advise, and correct, if you will. And you're not an expert, so you're allowed to be wrong. We are not allowed to be wrong on facts. We may be wrong on, we can do wrong assessments. Of course, we don't know nearly everything or even enough. That's different. But you're entitled to be wrong.
All right. Great. We have one question that just came in. It says, what information does my current healthcare provider need to send my new provider, and how can I help?
There is something that we developed in children's. I mentioned that it's called transfer summary. And if you happen to be cared for by somebody in children's who is not an epileptologist, they may not be fully in sync with it, but all epileptologists in children's hospital know of it. So basically that lists everything that is needed. And as I mentioned earlier, basically their nurse will fill everything in based on all available records. So that is the best way without now going into details. It basically contains everything from your birth history onwards, every possible risk of epilepsy, every medication you ever tried, every test that you ever had, and things of that nature. And it's actually even provides an assessment, what current diagnosis you have, how you responded to medications. All of this is part of this portable medical summary, the term that is used in these slides, but we simply call it in our jargon, transition and transfer summary.
Okay, great. One more. Some parents have expressed concerns about when to let go of managing their child's health care. So what can a parent do to prepare their youth and kind of slowly allow them to take control of their healthcare management?
Yeah. Well, I think it may sound trivial, but completely true. Early start is critical. And as much as the youth needs encouragement and practice, parents also need, let's call it an adjustment. I sometimes, I excluded from these slides, didn't want this to go over the board, but I have these situations that was in my office. So I'll just give you ultra contracted version of the story. So mom comes with a youngster who is 20 years old and who basically, just sitting passively. He's looking for a job, no problems, everything is good. And mom is holding a piece of paper and reading from the paper what she wants to talk. And then I said, excuse me, who is patient here? And she looks at me startled. She said, what do you mean? Don't you know that he's your patient? I said, is he? So she turned red. I said, that's why I want to talk to him. I don't want to turn to you. She was furious. So I spoke to him nicely, opened him up. He answered all questions. When we hit roadblock, we engaged mom. She was still mad at me, and then we finished everything. He walks out, she slams the door and hugs me and starts crying. And she said, thank you very much. So I, of course, said, just a second, let's open the door. No hugging behind closed doors and all that. I said, okay. And about 25 or 30 minutes ago, you wanted to grab my jugular with your nails. She said, exactly. I was mad at you. I said, and now? She said, I was wrong. You see, so this is just obviously a very blatant example that both sides need adjustment. Parents get into habit. I can tell you, I'm parent. Fortunately, my daughter is healthy, but I can tell you sometimes, I find myself doing too much for her with no reason. And interestingly, she even didn't ask. So we as the parents also, being parent, I'm obviously very cognizant of it. We think, well, it's much simpler to do this. Well, you have to realize it's like, how they say in those biblical stories, teaching somebody to fish and giving somebody fish. Those are different things. getting fish makes you survive once. Knowing how to fish prepares you for life.
Great, great. We had one more question that came up in the chat box. It says, what questions should I ask my new provider's practice?
The first key question is, first of all, did they receive records? Did they receive this transfer summary from your current pediatric providers? Do they have any specific requirement forms? Are those forms fillable on the internet, or do you fill paper forms? What forms are, if any, fillable in advance? Because there are certain things, you may be struggling in the office 15 minutes trying to recall things, but let's say if you can download them or fill them online, when you are sitting at home and everybody is relaxed and talking, you may be filling them more accurately, certainly more pleasantly. And then what is, for instance, one thing that I didn't emphasize during my presentation is, okay, what are their policies as to cancellation, as to being late or delayed? There are practices where you come 15 minutes late, done, out of luck. Well, there are practices you can come anytime, you have to wait and I'll see you. So for instance, if you ask me, our schedulers are obligated to contact us if patient is more than 15 minutes late. They contact us and say, Mr. Johnson just came, they are 25 minutes late. What do you want? Reschedule or wait? So what I tell, invariably, exception may be it's last patient and I'm already in hospital and they came 30 minutes late. Well, that's obviously different. But in most usual situation, basically I say, just explain to patient, I will see them for sure. They will have to wait, number one. Number two, whoever came on time gets seen first. That means they may be waiting next hour or 2 hours, because I don't want to piss people who came on time, right? Because of somebody who didn't come on time. But I want to be fair, I want to provide best care. I will see them. No matter, my clinic may be delayed an hour, whatever, I will see patient and I want to dedicate enough time that they need, that they feel that I'm doing best for them. So those are some things that are best to ask and be ready, to handle.
Okay, those are some great questions and a lot of great information. So we learned a lot today about planning through healthcare transition, and we had a fantastic speaker provided us with important steps to help navigate through the process of healthcare transition. So I want to take some time to acknowledge and thank Dr. Anto Bagic for his efforts. We really appreciate your willingness to be a part of this event. If anyone has any further questions or wants to connect with our speaker, please contact me through email, and I can provide you with some more information. So in closing, I want to thank everyone who registered for today's webinar and made transition a priority in your lives. I wish you all the best and hope to see you again at one of our future webinar opportunities that come up throughout this year. So thank you, everyone, and have a great day.
Thank you, Jordan. Thanks, everybody.